this is the second week, the last week of this course on precision medicine in psychiatry. And this Monday session is going to be focused on the interplay, the interconnection between cardiometabolic risk and cardiac mortality and severe mental illness. We have managed to arrange a program with very good speakers, with research experience from two very different perspectives, which are the nationwide cohort studies from epidemiology, and Benjamin Perry, who is going to talk more from cardiometabolic biomarkers and risk prediction, which makes the session, I think, very, very interesting. So Benjamin Perry, he's a doctor, he's a trainee psychiatrist, an early career researcher. He's a clinical lecturer at the Department of Psychiatry in Cambridge, and he has already over 30 first author publications and has been recently in receipt of a doctoral research fellowship from the National Institute for Health Research. His research interest is in the comorbidity between cardiometabolic and psychotic disorders, and his research has primarily consisted of genetic and observational epidemiological studies alongside a growing interest in clinical risk prediction, as I said before. His recent research has been also recognized by several awards, such as the European Psychiatric Association Research Prize or the Schizophrenia International Research Society Early Career Award. So we are really happy to have you here, Ben, and learn from all your research experience. Thank you very much.
Thank you very much. So let's get started. Okay, so I'm going to talk a bit about improving the identification of cardiometabolic risk in early psychosis. Thank you for the kind introduction, Javier. So I don't have any disclosures. So what we'll cover in the next hour is we'll talk about the cardiometabolic comorbidity of psychosis, and we'll talk about why the status quo isn't working. We'll talk about prognosis research as a tool to improve health outcomes in the general population and in the psychiatric populations, and the limitations of existing research. We'll talk about the development and the testing of our psychosis metabolic risk calculator, which was designed and tailored for young people with psychosis. And then we'll talk about some of the challenges about taking a risk prediction algorithm from print in a journal to being used routinely in clinical practice. So schizophrenia and the mortality gap. Schizophrenia, as you all know, if you have schizophrenia, you are likely to die much sooner than you would if you didn't have schizophrenia. So up to 10 to 15 years lower life expectancy than the general population. Here you can see in the grey dotted line, mortality rates in the general population. You can see that they're coming down over time. We aren't seeing the same improvements in people with schizophrenia. So they are coming down a bit, but by no means to the same extent as the general population. And so that mortality gap is getting wider over time. Cardiometabolic burden, cardiometabolic disorders is a leading cause of mortality in schizophrenia. So if you have schizophrenia, you're much more likely to be obese than the general population, much more likely to have type 2 diabetes than the general population. And that translates to a much higher prevalence of cardiovascular disease than aged matched members of the general population. And of course, cardiovascular disease encompasses endpoints like strokes and heart attacks, which essentially leads to that shortened life expectancy. In addition, the societal costs are huge of comorbid schizophrenia and cardiometabolic disorders, up to £700 million higher in the UK than the costs of treating those disorders separately. It's expensive and it's costly for both patients and society. What we can see here is research from the Swedish population. These are mortality rate ratios for different cardiometabolic disorders in people with schizophrenia compared with the general population. in different age groups. What we can see is that all-cause mortality is much higher in people with schizophrenia than in the general population, but substantially higher in younger ages. So in these younger ages, mortality rates are much higher in schizophrenia than the general population. And what we can see is that all-cause mortality rate that's higher is mostly driven by things like cardiovascular disease, myocardial infarction, and coronary heart disease. Over here on the right is a survival plot. And what we can see here is, so the dotted lines are the general population. This is survival after first hospital admission for cardiovascular disease in the whole population of Sweden. So survival drops down in the general population a bit and then sort of stabilizes. The corresponding color line in the solid line is schizophrenia. So if you have schizophrenia between 60 and 79, you survive. Your survival after first hospitalization drops off much more quickly. And actually that plays out in every age group, including younger adults and older adults too. So why do people with schizophrenia have higher rates of cardiometabolic comorbidity? Well, the received wisdom are that cardiometabolic comorbidity is a consequence of schizophrenia, i.e. you develop schizophrenia and then factors associated with schizophrenia lead you to have a higher risk of developing cardiometabolic disorders. For example, and there are many reasons why that might be the case, and they are important factors and ones that we'll come back to at the end of this lecture. So if you have schizophrenia, you might be less likely to eat a healthy, balanced diet, less likely to exercise regularly, and more likely to be sedentary. You might be more likely to consume more alcohol, and more likely to have a disturbed sleep. And all of these, as we know, are important cardiometabolic risk factors. And once someone develops psychosis, we prescribed antipsychotic medications commonly to nearly every patient with schizophrenia. And we all know that antipsychotic medications, they're not clean medications. As well as effects on the dopamine D2 receptor, they have effects on serotonin, noradrenergic, and histamine receptors. And different effects on those receptors can do things like increase appetite, change your glucose metabolism, change your insulin sensitivity. And that actually, it increases your cardiometabolic risk. And antipsychotics lie on a spectrum of cardiometabolic risks. This was a network meta-analysis by Toby Pillinger's group from King's College London recently, and show that actually that different antipsychotics have varying cardiometabolic effects. So things like haloperidol and aripiprazole have relatively lower cardiometabolic effects. Drugs like olanzapine and clozapine have higher cardiometabolic effects. And we know that cardiometabolic side effects occur very quickly after the first prescription of antipsychotics. Within weeks, weight gain can start occurring. Insulin sensitivity can start changing. These are very quick effects. In addition, inbuilt into the system, healthcare inequalities are really important, and they contribute to the increased risk of cardiometabolic comorbidity in schizophrenia. Here are some examples. So among hospital admissions for ischemic heart disease, people with schizophrenia were half as likely to be recommended for surgical interventions than the general population. And among hospital admissions for any physical health problem, people with schizophrenia had higher rates of infections, higher post-operative complications, and longer lengths of stay compared with the general population. And among those with diagnosis of type 2 diabetes, with schizophrenia are half as likely to be offered referral for specialist care. These are the barriers that are faced by our patients with schizophrenia, and these healthcare inequalities are an important contributor to the cardiometabolic comorbidity that we see and the shortened life expectancy. That aside, early markers of cardiometabolic dysfunction can be detectable from the onset of psychosis in young adults. So this was a meta-analysis that we published back in 2016, and this showed a range of measures of glucose and insulin homeostasis, insulin resistance, impaired glucose tolerance, for example, cases of psychosis had much higher rates, things like insulin resistance, impaired glucose tolerance, than matched controls. And importantly, these individuals are young. These were, first episode psychosis, peak age of onset of late teens, early 20s, and these were unmedicated individuals. And this was after adjusting for things like BMI, sex, ethnicity, suggesting that actually perhaps there's more to the story, and maybe there may be something else going on, and that direction of association might be slightly more complicated. Not only is have researchers found problems with glucose and insulin homeostasis, but also cholesterol and triglyceride levels too, in almost the same pattern of association with first episode psychosis compared with matched controls. And then let's take one further step back and look at at-risk individuals for developing psychosis. So even before the first episode of psychosis, people at risk of developing it have higher cardiometabolic risk compared with matched controls. That's been shown in cross-sectional studies and case control studies with ultra high risk status individuals, and with at-risk mental states as well, disrupted lipid homeostasis in case control studies, and fatty acid homeostasis is longitudinally associated with risk of psychosis in early adulthood. So we published last year the first longitudinal analysis of cardiometabolic function over time in childhood with psychotic disorders and other psychiatric phenotypes in adulthood. And what we did using the Ausbach birth cohort in the west of England, this was a birth cohort that started in the 1990s and recruited 15,000 pregnant mothers and their offspring and partners, and has followed them up now for over 20 years. The latest data release is up to age 24, and they're currently collecting age 30 data. What we did is we used a statistical technique called growth mixture modeling to track insulin levels and BMI. I'm just showing you insulin here. Insulin levels across childhood and adolescence. And then when we do that, we can delineate trajectories of insulin levels over time and find sort of different patterns of insulin levels over time in this group. So this was about 7,000 individuals. And this group here, so this is a Z transformed axis. So 0 is the mean. And this dark group here, this is the most common group. This was about 80% of individuals. As you expect, the most common group will stay around the mean. So what we're really looking at with the other two groups is the deviation away from the average insulin levels over time. There was a smaller group here of about 15% of individuals whose insulin levels go up very sort of slightly over time, over childhood and adolescence. And then there's another group here, a smaller group, only about 3 or 4% of the Ausbach population, whose insulin levels are much higher, even by age 9. Now, we couldn't go before age 9 because age 9 was the first time that they measured fasting insulin in Ausbach. But what you can see is that their insulin levels are substantially higher in childhood and throughout adolescence into adulthood. And when we tested associations with psychiatric outcomes, we found that this sort of persistently raised insulin group had a much higher risk of things like at-risk mental states and psychotic disorder at age 24, after adjusting for a detailed range of socioeconomic, demographic, and lifestyle confounders, suggesting that subtle alterations to cardiometabolic function could be detectable long before the onset of psychosis. So why might the direction of association between cardiometabolic dysfunction and schizophrenia be more complicated or even reversed, i.e., perhaps the cardiometabolic early signs of developing cardiometabolic comorbidity could predate the onset of psychosis? Well, there's a growing body of research to suggest that the same genetic variants that might predispose someone to developing schizophrenia may also, on the other hand, increase the risk of cardiometabolic disorders. And because we have more detailed and sensitive tests for cardiometabolic dysfunction, a blood test for fasting insulin, for example, perhaps we're picking up the cardiometabolic comorbidity first, even though the genetic variation is developing these things at the same period. That's one possibility. Shared environmental factors is also could also be another important implication. So there are many actually, but I'm going to focus on inflammation for the purpose of this talk, because abnormal levels of inflammation is strongly linked with schizophrenia, both cross-sectionally and longitudinally. Mendelian randomization studies, which I'll talk a bit more about in a moment, provide evidence that interleukin-6 and CRP could play a causal role in schizophrenia pathogenesis. And very similarly, it's almost like shining a mirror between schizophrenia and cardiometabolic disorders. A very similar pattern of abnormal inflammation is strongly linked with cardiometabolic disorders, both cross-sectionally and longitudinally, particularly relating to IL-6 and CRP. And a recent Mendelian randomization study has also shown in a very similar pattern that IL-6 and CRP could play a causal role in the pathogenesis of insulin resistance. Most of the research I've spoken about so far is observational in nature, and as in cross-sectional studies, case control studies, even cohort studies. The limitations of observational research, I'm sure we all are aware of. So things like reverse causality in non-longitudinal studies and residual confounding in any an observational study. One way of dealing with these limitations is a relatively novel type of study called Mendelian randomization. And it's essentially nature's randomized controlled trial. So in an RCT, what we aim to do is get a representative group of people, of a population, and we randomize them. We split them into an intervention group and a control group at random. If we have a representative enough sample and the randomization is good and is good enough, then what you'll get is that the confounders will be evenly split between those groups, and therefore you can deal with residual confounding. And therefore, when you compare the outcomes between those groups, you can and the only difference in those groups is that one got the intervention. You can suggest that the difference in outcome is because of that intervention. In Mendelian randomization, it borrows from Gregor Mendel's work, who discovered that alleles are randomly allocated at birth. So if we know, for example, a specific genetic variant is strongly related with the levels of a modifiable exposure, we can use that genetic variant as a proxy for that exposure. So for example, if there are two variations of a genetic variant, one increases the risk of insulin resistance and one doesn't, we can compare every single person who has it from a GWAS study, genome-wide association study. We compare outcomes between everyone who has that genetic variant and everyone that doesn't, and then we can infer from that causality because of that difference and because of that the effects of that genetic variant on that modifiable exposure. And essentially, Mendelian randomization aims to address the limitations of observational studies such as confounding and direction of association. So we did a Mendelian randomization study of cardiometabolic dysfunction and schizophrenia. And it was a bidirectional study. So we looked in both directions so we could assess direction of association of 10 cardiometabolic traits: insulin, triglycerides, HDL, LDL, type 2 diabetes, plasma glucose, glycated hemoglobin, glucose tolerance, and BMI. And this was the sort of the first analysis. It was just to look at the associations of these traits on schizophrenia. And what you can see is that all of the confidence intervals are crossing 1. And in an odds ratio, we know that means that there's not strong evidence that any of these cardiometabolic traits could be causal for schizophrenia. Next, considering a hypothesis that inflammation could be a common cause for insulin resistance or other cardiometabolic dysfunction and schizophrenia, similar to the research I spoke about on a previous slide, what we did is we looked again at these genetic variants, and we found ones that were also strongly associated with a measure of inflammation. And when we did that, we found something slightly different. So we found a strong association between inflammation-related insulin, inflammation-related triglycerides, and inflammation-related HDL cholesterol with schizophrenia. Now, a positive association for fasting insulin and triglycerides, and a protective association for HDL. This pattern of raised insulin, raised triglycerides, and low HDL is pathognomonic of insulin resistance. This is the phenotype of insulin resistance. And what this suggests is that the inflammation could be a common cause for insulin resistance and schizophrenia. To further test that, we looked at sort of different strengths of association between those genetic variants with measures of inflammation. And so, for example, here you can see that these were all the genetic variants for these traits. We don't see an association. When we look at p times 10 to the minus 5 of an association with inflammation, we see some effect. And then when we increase that to p times 10 to the minus 8, i.e. genome-wide significance, we see a much stronger association. And this sort of stepwise increasing in association between these cardiometabolic traits and schizophrenia suggests that inflammation could be this common cause. When we then conducted multivariable Mendelian randomization, which is just like a multivariable regression analysis where you add in covariates, the covariate that we added was CRP. And when we did that, when we adjust for CRP, these Mendelian randomization estimates attenuate completely to the null. Further evidence that inflammation could be what's driving this association. Okay, so here's a summary so far. People with chronic schizophrenia sadly shoulder significant life-shortening cardiometabolic burden. The consequences of the psychotic illness, things like lifestyle factors, healthcare inequalities, and antipsychotic medications, they're important, and they are really important, and we'll come back to them at the end, but they may not be the whole story. Schizophrenia may carry an inherent cardiometabolic risk, either due to genetic or environmental influences, or a mixture of both. Abnormal cardiometabolic function could be detectable before the onset of psychosis in young adults. So, knowing all that, what can we do about it? The premise of early intervention applies equally to cardiometabolic health as it does psychiatric health, i.e. intervene early and reduce the risk of poorer longer-term outcomes. The time young people spend with psychosis early intervention services is a key window of opportunity to influence health outcomes, both psychiatric and physical. An accurate identification of individuals more at risk of poorer longer-term outcomes could permit the personalized tailoring of treatment in advance to reduce or prevent those poor outcomes from occurring in the first place. So let's talk about clinical risk prediction. Clinical risk prediction is distinguished from this sort of traditional observational research is that it analyzes at the level of the individual rather than the group, as you would see in a regression analysis. Estimates, prognosis research estimates the accuracy in which a prediction model, which is just either a regression equation or a machine learning model, for example, can capture enough variance to reliably estimate the chance of that poor outcome occurring in advance. If you're interested in developing or evaluating a risk prediction model study, I recommend this paper. This is a step-by-step guide for the development and validation and appraisal of risk prediction model studies. But essentially, whereas if we're looking at observational research, we're looking at things like odds ratios and p-values. In risk prediction, we're looking at things like discrimination, commonly reported as a C statistic. And what that is the probability that a randomly selected case of outcome has a higher probability score from the risk prediction algorithm than a randomly selected non-case. That's important, but so is calibration. And that and they are commonly presented via a plot, a calibration plot, and that shows you the agreement between the observed risk in your sample and the predicted risk, that the number, the size of that probability that comes out of the risk prediction algorithm. How accurate is it? And then we might think about clinical usefulness with a decision curve analysis, and I'll show you that some examples of that as we move through the talk. So this is a very brief, simplified overview of how you develop a risk prediction algorithm. So essentially, you have a group of people and you fit a regression equation in that sample. The regression equation is just all of the predictors that you're interested in. You fit them as a regression equation in a sample. Now, the gold standard is to externally validate your algorithm, because you can't know that just because you've tested it in one sample, how is it going to perform in the wider population as a whole? So what you do is you develop in one sample, and ideally you test it in a completely unseen separate sample, which might be separated either by geography, so somewhere else but in the same population, or time. So for example, you might have data from this decade and you test it in data from the last decade, for example. And so that would be external validation, and it's the gold standard for clinical risk prediction models. Often two samples aren't available. It's very difficult to get one cohort with long enough follow-up, let alone two. And if you don't have access to two samples, then you can internally validate your algorithm. And you commonly see this in the literature. They're the next best thing, but they can't do what external validation can do. They can't show generalizability to the wider population at whole. So essentially what you do, if you're going to internally validate, if you only have one sample, is you fit your regression equation the same as before, but only in, for example, half of your sample. And then you use fancy statistical techniques like bootstrapping or cross-validation to repeatedly test your fitted equation in small unseen sections of the same sort of sample that you've got. And then you get sort of an averaged estimate of the performance. So cardiometabolic risk prediction in the general population is extremely common. In the UK, for example, we have something called the Q-risk calculator. It's used up and down the country every day in general in family practices. In fact, GPs, family doctors, are paid their funding. A part of their funding comes from how often this tool is being used to help stratify individuals for heart disease risk. So Q-risk3 predicts heart disease. What these things do is they return a personalized probability for an adverse cardiometabolic outcome in the future. And typically in the general population, we're looking at between 5 and 10 years in the future. And they are used as tools to encourage personalized treatment decisions with the aim of primary prevention. For example, a Q-risk score, if your score comes back over 10%, then you're eligible to be prescribed a statin. And that is generally how GPs decide who is prescribed a statin in the general population. So this is, I actually filled out the Q-risk3 calculator in advance of this talk. So this is my information. And then these are the results that I get. So my risk of having a heart attack or stroke within the next 10 years is just 0.5%, which means in a crowd of 100 people with the same risk factors as me, one of them is likely to have a heart attack or stroke in the next 10 years. Now that is very low. It's a very low risk. That's 20 times lower than the risk it would need to be for me to be eligible for statins. And I'm going to tell you why that's the case. It's not necessarily that I'm super healthy. It's because I'm 33 years old. And we're going to go through that and I'm going to lay that out for you in just a little while. So we performed a systematic review of existing cardiometabolic risk algorithms that were either developed for the general population or psychiatric populations. And we did that to see whether any of them might be suitable for young people with psychosis. The main message is there are loads of these things, hundreds of them. We included about 200 studies in our systematic review, and actually each of those studies probably had 3 or 4 different versions of their algorithm. So we're talking closer to 400, 500 risk prediction algorithms that were included in this review. Only one of them was developed in a psychiatric population. That's David Osborne's Primrose calculator, David Osborne from UCL. And a further 2 included psychiatric predictors, things like antipsychotic medications. And they're the 2 newer versions of this Q-risk algorithm for the general population. Importantly, all of them were developed in samples of older adults. We're talking, average age of 40s to 50s, up to 60s at recruitment. And most of them actually were at high risk of bias or were reported very poorly. Very few of them were externally validated, As I said, that it's difficult to get access to 2 samples, but you need access to 2 samples to show generalizability of an algorithm. Then we performed a validation analysis of 3 of the better of the algorithms that we thought actually maybe this one would be suitable for young people with psychosis. That was the Primrose study, because it was developed for a psychiatric population, and Q diabetes and Q risk, because they included psychiatric predictors. And we tested them in a sample of young adults with psychosis from the Ausbach birth cohort. So they were age 18 at inclusion and age 24 when we assessed the outcome. And this is a calibration plot of the Primrose calculator in Ausbach. And actually, I could have showed you the plots for Q diabetes and Q risk. They looked exactly the same. A calibration plot, as I mentioned before, shows the agreement between observed and predicted risk. So if the predicted risk is 0.2, what we want to see is that the actual risk is 0.2. So perfect calibration will trace this grey line up the middle. Now, what we're seeing here is something completely different. This calibration line is on almost a different planet. What this is showing is substantial under-prediction of risk in young adults with psychosis. For example, if the predicted risk is 0.2, the actual risk is closer to 0.8. So if we use these existing algorithms, we are massively under-predicting risk in young adults with psychosis. And from that, we concluded no existing algorithm is likely to be suitable for young adults with psychosis. Now, I mentioned that age might be important, and let me just highlight that for you here. So this is the relative weighting of different predictors that go into the Primrose risk prediction algorithm that was developed and tested in older adults with mental illness. So this here is the weighting for age compared with the weightings for all of the other risk predictors that go into the Primrose algorithm. Essentially, if you are young, you cannot score highly on these risk prediction algorithms. You could have every single other risk factor under the sun, but if you're young, you will not score highly because you're young. Age is a more important risk factor as you get older. So in older adults from the general population, age is an important risk factor. And that's why age is weighted so heavily here. In young people, that is not the case. These other risk factors are much more important. And so the balance of the weighting of these different predictors in the algorithm is just off for young people. So we aim to develop and externally validate an age-appropriate, clinically useful risk prediction algorithm for young people with psychosis. So this is the Psychosis Metabolic Risk Calculator. It was developed and externally validated in a sample of 1,100 young adults with psychosis from an early intervention services in Cambridgeshire, Birmingham and South London in the UK. And it was a forced entry penalized logistic regression model. I won't go over that too much, just to say it was just a simple logistic regression model that, and then what we did is we shrunk those weightings, those coefficients a little bit for over-optimism using bootstrap internal validation. And I can talk more about that at the end if anyone is interested. But just to say that this method is generally, what we did is essentially we didn't take 100 different predictors and use machine learning to whittle them down. We just picked that we know what is will increase cardiometabolic risk in this population. So we just chose the risk factors that we know are likely to be important. We designed it to be clinically useful. So what we did is we developed 2 versions of Psymetric, one that includes blood test results and one that doesn't. The one that includes blood test results, we chose HDL and triglycerides because they're commonly measured in the general population, but not because we're interested in HDL or triglycerides. We're interested in insulin resistance. We know that insulin resistance is really important in early psychosis, but there are virtually no clinical services in the UK that will measure insulin resistance in early intervention patients. However, a triglyceride to HDL ratio is a very good proxy for insulin resistance. If your triglycerides are up and your HDL is down, that ratio is a good proxy for insulin resistance. As I showed you in a previous slide, that sort of phenotype of insulin resistance includes raised fasting insulin, raised triglycerides, and low HDL. And HDL and triglycerides are commonly measured in services in the UK. We also designed the algorithm to be acceptable to patients. So we worked with a young person's advisory group. These were young people with lived experience of psychosis from a charity in the UK called the McPim Foundation. So we included antipsychotics as a predictor in our algorithm, where existing algorithms either sort of distinguish risk by either first or second generation or typical or atypical antipsychotics. The sort of the cardiometabolic risk of antipsychotics doesn't necessarily sort of fit those categories at all. So we used existing research to distinguish more metabolically active antipsychotics from less metabolically active antipsychotics, and these were the categories that we used. So the outcome was metabolic syndrome because it's sort of an age-appropriate cardiometabolic intermediate, and metabolic syndrome is strongly associated with future risk of diabetes, heart disease, strokes, heart attacks, and early mortality. And therefore, metabolic syndrome is an important marker of past, present, and future cardiometabolic risk. So this was a simplified overview of our methods. So we fit the logistic regression equation with those predictors that I showed you on the previous slide in a sample of patient data from Birmingham and Cambridgeshire early intervention services. Then we shrunk those, as I mentioned, shrunk those predictor coefficients because we thought that they might be over-optimistic, fit in a relatively small sample. I mean, a relatively big early intervention sample, but relatively small sample for the development of risk prediction algorithms. And then we tested that equation we just took that equation, shrunk the predictor coefficients, and tested it in a sample of similar sample of age 16 to 35. Early intervention service patients from South London, so in 510 patients. And this is what we found. So this is what a calibration plot should look like. This is an external validation. You can see very good agreement between observed and predicted risk, suggesting that the risk prediction estimates that you get from this algorithm are likely to be accurate. We had C statistics for both models of above 0.7, suggesting good discrimination. So essentially the algorithm performed very well. And if you want to play around, we have a data visualization tool at this address, and I can pop that in the chat at the end if anyone is interested. Here is a decision curve analysis. So what this shows is the net benefit of using Psymetric to help you decide which interventions to give someone to reduce their cardiometabolic risk. The net benefit is the number of individuals who will later go on to develop the outcome that you can give an intervention to before the outcome happens to hopefully prevent that outcome from developing. The higher the net benefit, the more the more individuals that would likely develop the outcome you can intervene on. So the maximum net benefit is the prevalence of outcome in the population, because you can't intervene on more cases than there are cases, future cases. So the prevalence of outcome was about 18% metabolic syndrome in our sample. And what you can see here is that the net benefit changes depending on the risk threshold. This risk threshold is the level of risk that you are willing to accept before you think an intervention is necessary. For example, you might think that everyone could do with some lifestyle advice. I mean, many people could do with some lifestyle advice. There's not much risk associated with just, asking someone to do a bit more exercise or eat more healthily. Therefore, you would accept a lower risk threshold before you gave that intervention. For things like switching antipsychotics, or maybe saying that a young person with psychosis maybe shouldn't be prescribed something like olanzapine, or you think about prescribing something like metformin, which might have other side effects, you might accept a higher risk threshold because there might be unintended consequences with those decisions. So you might accept a higher risk threshold before you decide to intervene. And therefore, what we can see here is that Psymetric conveys net benefit at all risk thresholds that are likely to be feasible. We only went up to 0.35 here because we thought that if someone was, having an over a 35% chance of having metabolic syndrome in the next 6 years, really you should be doing something. It's, you don't need Psymetric to help you there. You should just be doing something. a cutoff score of 0.18, Psymetric would improve net benefit by about 8%. And that means essentially a 47% increase in detected cases of metabolic syndrome. And that equates to around 8 additional cases of metabolic syndrome that you can intervene on per 100 individuals without any increase in false positives. So we could, per 100 individuals, we could prevent an additional 8 cases of metabolic syndrome if we use Psymetric to help guide our choices for interventions. But algorithms are only suitable for use in populations they've been tested in. Global populations could vary in things like culture, ethnic makeup, dietary habits, social norms, legislation. There are many factors that may mean one population in one country is different from a population in another country. And all of those factors can limit the generalizability of a risk prediction algorithm to a new population. Even large-scale general population-based risk prediction algorithms, for example, the Framingham risk score and Q-risk, show varying performance in different populations, different global populations, I should say. And therefore, we wanted to test whether Psymetric actually can be useful outside of the UK, because, of course, the metabolic dysfunction associated with psychosis, it's a global problem. It's not just a UK problem. So what we did is we tested Psymetric in 2 European samples. So the first sample was Psymetab from Switzerland. It's a cohort study from Lausanne in Switzerland. So recruitment started in 2007 and it's ongoing. It includes children, adolescents, adults and seniors. Metabolic parameters were collected at baseline and then regularly after that and are still being collected now. It's a really rich data set. They've got over 15,000 data points across 400 variables. The second sample was the PAFIP sample, which I imagine everyone in this audience knows very well. It's your sample. This is your cohort study. So I hope I've got this right, that recruitment started in 2001. It includes adolescents, adults and seniors and is ongoing. It's a rich data set, including socio-demographic, lifestyle, biochemical and neuroimaging data. And you've got over 850 participants so far. So this is just how we applied the inclusion criteria to our study. So essentially, we started with a total sample. We only included those aged 16 to 35 to match the population that we developed the algorithm in. So we dropped some participants there. We only included those with psychosis spectrum disorder diagnoses, those that are likely to be under early intervention services, but wherever they may be. So we drop a few more participants. And then we only included those that had follow-up data available between 1 and 6 years after baseline so that we could calculate an outcome. And then we excluded those that had metabolic syndrome at baseline, which is an important step, because if you don't do that, you can artificially inflate your performance statistics. So we measured the predictors at baseline. We calculated the metabolic syndrome outcome variable from clinical and biochemical variables at the longest available follow-up from each participant with the least amount of missing data. We addressed missing data with multiple imputation. So the proportion of missing data was actually relatively low in both samples for most variables, lending itself well to multiple imputation, where we could include suitable auxiliary variables. Predictive performance was assessed using measures of discrimination, calibration, and decision curve analysis, like I've shown you already. And then we considered recalibrating the algorithms to make specific site-specific versions, i.e. like a Spanish version of Psymetric and a Swiss version of Psymetric. So I won't labor over all of these numbers, just to show you that the samples were relatively similar, but did have some key differences. So that the prevalence of metabolic syndrome at outcome was a bit higher in Switzerland and a bit lower in Spain than the UK. And the follow-up time was actually very good. So it's longer than we had in the UK. Many of our participants smoked. So here are the results from Switzerland, first of all. So here is the calibration plot. So again, the calibration isn't as good as the UK, which we might expect because it's a different population, but the C statistic is very good. So, but after we sort of calibrated, so we sort of rejigged the algorithm to make a Spanish version, we see perfect, a Swiss version, we see perfect calibration. Again, with the partial model that doesn't include blood test results, we again see some under prediction of risk particularly at higher predicted probabilities. But again, that completely mends itself after logistic calibration. But decision curve analysis shows that either using the UK version in Switzerland or the recalibrated version does lend net benefit because we're above 0 at all risk thresholds. Now the results from Spain. So you in your cohort, the PAFIT cohort, we see good C statistics for the full model. That's the model that includes blood test results. What we do see some under prediction of risk in the calibration plots that again fixes itself completely after rejigging the algorithm, calibrating the algorithm. And then in the partial model, we see much better agreement between observed and predicted risk, really good calibration plot that again is improved even further after logistic calibration. And again, we see net benefit of using the algorithm in Spain. So it's likely to be clinically useful in the UK, in Switzerland and Spain. Again, if you visit this link or you shine your phone at this logo, you can get to our online data visualization where you can look at the results and sort of visualize different risks and visualize the data in the UK, Spain and Switzerland. How can Psymetric be helpful? So I've shown that it's likely to be clinically useful using statistical technique in both UK, Spain and Switzerland. But any risk prediction algorithm is useless by itself. It's not useful by itself. A risk estimate is just a number. It's just an algorithm on a computer that gives you a number. That number needs to lead to something. It needs to translate into an action to exert any benefit and any influence on patient outcomes. For the clinician, for example, Psymetric can encourage targeted interventions, things like behavioral interventions, lifestyle interventions, or even pharmacological interventions. We could be better informed about antipsychotic prescribing or antipsychotic switching, and we could consider stratification for more intensive physical health monitoring in individuals at higher risk. For the patient, Psymetric might encourage dietary changes, increasing physical activity, and it might be good motivation for something like stopping smoking, for example. Research in the general population does suggest that cardiovascular disease prediction tools have strong impact on clinician behavior, but they don't have that much impact on patient behavior, either positive or negative. So there are some pros and cons there, because essentially what these algorithms lead to in the general population anyway are changes to what clinicians do, changes to what we do. We might we might see a risk prediction estimate and change our habits of prescribing or behavioral interventions, but they don't lead to changes in patients, either positive or negative. So they don't lead to changes in behavior, but they also don't lead to negative impacts on psychological functioning as well. So here's just an example that was taken from our publication for how Psymetric could be helpful. I won't read it all out, but this is just a case of a made-up case of a 24-year-old South Asian male who is admitted with psychosis. His BMI is normal, but at the upper end of normal, doesn't smoke, but his blood test results show high triglycerides and low HDL, possibly insulin resistance. So his initial score is 13, 0.13 or 13% of developing the outcome. If he's prescribed aripiprazole, his change doesn't score. His score doesn't change. If he's prescribed olanzapine, his score increases by 46%. He then has some residual symptoms, so he opts to remain on an antipsychotic medication. He sees a dietitian to address his cholesterol levels, and after a year, he's a year older, but his triglycerides have come down and his HDL has come up and his BMI has decreased to 23.3. So the doctor talks to him about a change in medication. If he continues on aripiprazole, all of those lifestyle changes that he made have led to a 46% decrease in his risk of metabolic syndrome if he continues on aripiprazole. Even if he switches to olanzapine at this point, after addressing his lifestyle factors, he still has a decreased risk of metabolic syndrome. This just shows that we don't need to just not prescribe things like olanzapine, things like quetiapine, things like risperidone. They can be prescribed safely in people who may be at high cardiometabolic risk, as long as we're very pertinent about addressing those other factors, BMI, exercise, diet, things like that, then we can safely prescribe these tablets. The problem is going from print to practice in risk prediction models is really hard. So there are loads of risk prediction algorithms out there for nearly every single medical outcome you can ever imagine. How many of them are used in clinical practice? Well, hardly any. The problem is it's really hard to do. So you've developed your algorithm, you've externally validated it, you externally validate again. So this is about where we're up to with Psymetric. But then, as I mentioned, that an algorithm is nothing by itself. It needs someone to do something with that result to influence a patient outcome. Therefore, an algorithm needs to become part of a complex intervention that needs to undergo a clinical trial. In the UK now, risk prediction algorithms are classed as medical devices, the same as like an anesthetic machine. It would be regulated the same in the same way. So it needs regulatory approval, and then a whole package of implementation to help it actually be used in clinical practice. And at the same time, you need to keep testing it and keep testing it to keep showing it works. That's a lot of work, and it's hard. This is how I see the future of physical healthcare in psychosis early intervention. So a young person will be enrolled in a service. They'll have a psychometric score calculated. They'll be delineated into different risk groups. Everyone will have universal interventions, things like lifestyle advice. And then, depending on your level of risk, you might get more intensive or higher risk interventions and more frequent monitoring if you're higher risk, and perhaps less intensive and lower risk interventions, less frequent monitoring if you're lower risk. And then at yearly checkups, this score can be recalculated, and we can ensure that people in the higher risk groups are moving downwards, and what we don't want to happen is people in the lower risk groups moving upwards. The future of Psymetric, so it needs refining in larger samples. We could think about more complex modeling of antipsychotics, for example, modeling them individually, more granular modeling of ethnicity, and including additional predictors. We need more international samples to bring us closer toward a globally useful cardiometabolic risk prediction tool for young people with psychosis. Please do get in touch if you have data or ideas that you can work with us to help us improve, refine, and test Psymetric in the future. It'd be great to collaborate. So I'd like to thank many individuals that have helped me so far, particularly related to this talk: Javier, Natalia, Benedicto, Victor, from the PAFIC group, and my supervisors too. Thank you very much for listening, and if there's time, I'll answer any questions.
Benjamin, thank you very much for this wonderful presentation. I would like to know if metabolic disorders are associated to other psychiatric disorders such as depression.
Yeah, they are in a strong way. You know, you see similar associations with heart disease in other severe mental illnesses like depression and bipolar disorder, and many of those traditional attributions that I spoke about at the start, things like diet, exercise, healthcare inequalities, apply equally across mental disorders. It's not schizophrenia specific. And you know, we're starting with psychosis with Psymetric, but you know, we could broaden that and develop tools for other groups because they're also in need of such tools.
Indeed, I think it's a very interesting line of research, Benjamin, you are working in. How far is Psymetric from being used in clinical routine, like the pure risk 3? Is it?
Yeah.
Because it is used for by GPs, as you said, in daily routine clinic, and I guess it's also an algorithm as Psymetric is. So, do you think we will get to that point?
Yeah, I think we do, and I'm very keen to stick with it actually, and to see the course. I mean, I think when I when I went to get the funding for the development of Psymetric, I was keen to point out that these algorithms, many of them, they're developed, sit in the literature somewhere in a journal publication, and then never get used and just get forgotten about. I'm really keen that that isn't the case with Psymetric. There is a lot of work ahead. So as I mentioned, we need to integrate the algorithm as part of a wider complex intervention that we can undergo a clinical trial. So that's the next step, really. Once we can show that that works, then we can start integrating it. And we know we can integrate it in the UK, and we've got now data from Spain and Switzerland, at least, so we know that we can start hopefully to integrate into those countries, and hopefully we can extend that even further too. But there is a lot of work ahead.
So you said that probably you have to include other biomarkers or other variables.
Yeah.
I guess probably hereditability or genetics, no? Because when you look for cardiometabolic risk, you normally ask for family history of cerebrovascular or cardiovascular events. Are you designing or doing this process in parallel, including other variables at the same time as replicating the study in other cohorts or samples?
Yes, that is the plan, exactly. So, I mean, the accuracy of Psymetric was good, but it could be better if we want it to be used every single day, like the Q-risk is in the UK. The genetics thing is really interesting, actually. So in the UK now, they've rolled out the use of polygenic risk scores to help predict heart disease in some centres as a trial. Now that was based really from a few papers, but one in particular where they looked at the improvement in risk prediction if you had a polygenic score for heart disease at baseline. How much does that improve the way you can predict risk at outcome? So that was tested in a massive sample from the UK Biobank, and actually in terms of a C statistic, the improvement was like 0.01 of a C statistic, and I think there's an interesting hypothesis there that maybe that in older adults, because participants in the biobank are relatively older, much of what the genotype is doing to increase cardiometabolic risk is probably already being shown in a phenotype. So, for example, genotype might increase your risk of smoking or might increase your appetite, and therefore that's shown in your smoking or history or in your BMI. But in younger people, that translation between genotype and phenotype might not be as strong, and therefore the genotype, when tested in younger people, might convey more improvement to risk prediction. So I think it's a really interesting hypothesis, and what I'm really keen to test. The problem is there aren't that many samples that have all of the data that we need, both psychiatric data, genetic data, and the cardiometabolic indices. I mean, your PAFIP sample is great. I mean, there aren't many samples like it, and there aren't many others like PAFIP either.
Thank you.
Thank you. Thanks so much for having me.
Thank you very much, Benjamin, for your talk.
Thank you very much.
Then our next speaker is Professor Nielsen. René Nielsen is professor of psychiatry at Aalborg University in Denmark. He's a psychiatrist at the Department of Psychiatry at Aalborg University Hospital, and he's currently working at the research and treatment program for bipolar disorder. He's head of a research program for mood disorders, as well as head of research program for mortality and morbidity, which focuses primarily on register-based studies in patients with severe mental disorder. He has led and co-authored over 80 research papers in this area, and he has recently been appointed National Coordinator for the Trial Nation Network for Psychiatry, which is a network funded by public Danish institutions. He's also assistant editor for the Nordic Journal of Psychiatry and BMC Psychiatry. And well, it's a real pleasure to have you here, René, listening to you. Thank you very much.
Thank you very much, Javier, and very much thank you for the kind both invitation and the presentation. I'm going to talk about severe mental illness and cardiovascular disease primarily, and a bit about arrhythmias as well. We're looking a bit into that area, and if we have time, I'll just jump in a bit. Then I'm going to talk about what we learned from cohorts and real-world evidence and how that might be important for how we can handle the increased risk of cardiovascular disease. And there I go. I'm located in Aalborg. This is Denmark. To the top right, there's Sweden, and you can just see the tip of Norway. Aalborg is not known for anything basically, except perhaps that we have some beautiful seaside buildings. We have the largest carnival in the northern part of Europe, and we have the longest street with solely bars. So if you're visiting, you can decide, do you want to see the architecture, the samba festival, or do you want to see the party street? New York Times visited, they chose, I don't know why, the architecture, but there is plenty to see. Short disclosure slide. I've gotten research funds or been appointed as an investigator for Lundbeck, Compass, or Otsuka. I've gotten speakers fees from Bristol Myers Squibb, Astra, Janssen Cilag, Lundbeck, Servier, Otsuka, Teva, and Eli Lilly, and I've been appointed as part of advisory boards for AstraZeneca, Eli Lilly, Lundbeck, Otsuka, Takeda, Janssen, and Medivir. I still hope you'll find my talk balanced and fair. If not, please let me know. So, initially talking about real-world evidence. If you're not used to working with register-based research from where most of what we call real-world evidence originates, it's nice to know that most databases are either local or based on insurance databases. Some countries like Denmark, Norway, Sweden, Taiwan will have more worldwide based, more nationwide based databases where you can follow patients even if they move within that country. For example, in Denmark, you could have a single case, a patient, let's say, defined by having a schizophrenia diagnosis. We define the patient according to the psychiatric register. We're able to look at which medications they have gotten over time. We can also look at which other healthcare treatments they have received. You can add that to the cause of death register, and you can also add in the GPs, general practitioners, by looping in the prescription database. Increasingly, at least in Denmark, but also in many other countries, some of the simple treatment of cardiac risk factors, for example, increased cholesterol levels or simple hypertension, is treated by the GPs. So, before we go into cardiovascular disease, I would just like to point out a few things from previous publications. This was a publication one of my PhD students did, looking into mortality from multimorbidity in patients with schizophrenia. Patients had increased occurrence of somatic diseases. Looking into number of somatic diseases a bit down on the page, you can see zero somatic diagnosis was only seen in 12% of patients with schizophrenia as compared to almost 43% of the general population. Looking into 1, 2, 3, 4, or more than 5 diagnoses, patients with schizophrenia had a higher proportion of having diseases, both single diseases but also multimorbidity. Looking at the proportion of different diagnoses, patients with schizophrenia had an increased rate of all diagnoses except cancer, where patients from the general populations had a bit of an increase compared to patients with schizophrenia, which is most likely due to patients with schizophrenia dying at a younger age. If you look at the risk associated with having a single disease compared to 1, 2, 3, 4 of more than 5 diseases, if we have the adjusted model on the right, you can see in the general population, we added 0 diseases as the reference. Patients with schizophrenia, even if they're not diagnosed with any diseases, have an increased risk of mortality of almost a hazard rate of 5. When jumping up to 1 disease, patients in the general populations have relative to zero disease, an increased risk of a factor 4 compared to a factor 16 in patients with schizophrenia, and adding on when we go up. So patients with schizophrenia have a much larger burden when diagnosed with diseases, and they have an increased mortality rate. When we look at this very special model that needs a few words, in this model we tried to adjust for every single diagnosis. We adjusted for age, gender, calendar year, a number of diagnoses as well. Even when we adjusted for everything, including the disease, patients with schizophrenia had an approximate increased risk of death of a hazard rate of 2 to 3. So even when we adjust for everything, having schizophrenia is associated with an increased mortality rate. So having a severe mental illness, it's the same for bipolar disorder. Even when we adjust for everything we have diagnosed, we see an increased mortality rate. Looking at patients with schizophrenia, this is the old Katie study, a randomized control trial from 2005, looking at patients who were followed over time, treated with olanzapine, quetiapine, risperidone, perfenazine, or ziprasidone. Everybody had a weight gain. So on olanzapine, patients on average increased their weights with 2 pounds per month of treatment. On quetiapine, 0.5 pound. On risperidone, 0.4 pounds. On perfenazine, they on average lost 0.2, and on ziprasidone, they on average lost 0.3. They had increases in blood glucose, they had increases in cholesterol. So antipsychotic treatment seems to affect metabolic risk. As I just saw the last part of Benjamin's talk, so I think you already went through that. I'm just gonna skip over it pretty fast. Looking at a very old meta-analysis on weight gain. I use this because I like the slide, the table. It's necessary to think in relative terms regarding antipsychotics and the tendency for weight gain. So I'll just diminish myself a bit so you can read everything. Looking at placebo, which is not related to weight gain, every single drug afterwards has an increased risk of weight gain, not necessarily statistically significant, but ziprasidone, fluphenazine, haloperidol, polypharmacy, risperidone, chlorpromazine, sertindole, furasidone, olanzapine, and clozapine. So everything increases. This also means if you go from, let's say, ziprasidone to risperidone, you'll most likely get weight gain. If you go from olanzapine to risperidone, the patient has a chance to experience weight loss. Looking at antipsychotics, we just saw all the risks associated with antipsychotics, the risk of weight gain, the risk of increases of blood glucose, the risk of increases in cholesterol. But antipsychotics are also important for treating psychotic symptoms, or at least psychiatric symptoms, also used in bipolar and unipolar depression. Looking at the risk, let's just look at schizophrenia. Being on atypical antipsychotics or haloperidol decreases the risk of any cause, all-cause mortality by almost half compared to placebo. So despite of antipsychotics having a lot of side effects, you also gain something. So it's kind of a two-sided thing. You have some risk associated with being treated with antipsychotics, but also some gains. It's important to remember that when changing medications, it's not necessarily only due to metabolic side effects. Similar, if you look at the risk of suicide, the effects are smaller for antipsychotics in schizophrenia, but they still decrease the risk of suicide. Looking at the FIN-11 study by Tihonen, which was published in 2009 in Lancet, which was one of the first early on real-world evidence data sets looking at the risk associated with antipsychotic treatments and the risk of death in patients with schizophrenia. In the first part of the figure, They showed that clozapine was associated with a decreased risk of all-cause mortality. Perfenazine polypharmacy, olanzapine, and flurazidine was not associated with an increased risk, and the remaining antipsychotics increased the risk of death. Everything was better than not being treated. Looking at the B was suicide. Similarly, clozapine remarkably reduced the risk of suicide, and the remaining antipsychotics did not affect the risk of suicide. And most interestingly here, if you're looking at clozapine, olanzapine, and quetiapine, those are the three numerically top drugs to decrease cardiovascular disease. It's not strange with clozapine. Patients treated with clozapine are a specific subtype of patients. They are patients that are more able to come into the office. It's patients who are commonly being monitored with blood samples due to the risk of low platelets and low leukocytes. But the remaining two drugs, quetiapine and olanzapine, which most often is associated with the risk of metabolic syndrome, do not significantly increase the risk of cardiovascular disease. So it's kind of, you have some gains, you have some losses, and comparing antipsychotics in generally seems even those who have a severe metabolic side effect profile seems to decrease the risk, or at least not increase the risk of metabolic disease causing death. Again, looking at real-world data, 20-year follow-up study of physical morbidity and mortality in patients treated with antipsychotics, patients diagnosed with schizophrenia spectrum disorder. Once again, comparing antipsychotics to no antipsychotics, patients treated with antipsychotics had a lower risk of mortality. And the last general comment before we go into cardiovascular disease, antipsychotics differentiated into different classes on mortality. Again, first generation antipsychotics did best compared to, second generation antipsychotics did best compared to first generation, but everything was better than being not treated with antipsychotics. So in general, you see the lowest cumulative mortality rate being associated with being treated and exposed to antipsychotic drugs when looking at real-world evidence data. So it's important to differentiate between the data from randomized controlled trials, where there's kind of a risk that you only have the very compliant patients included. Compare that to real-world evidence, where you have a much wider group of patients, and you're able to show some of the non-specific effects of antipsychotics on mortality. Looking at the risk associated with being diagnosed with severe mental disorders, looking at the expected life expectancy in Finland, Denmark, and Sweden using register-based data, substance misuse decreased the average or the life expectancy with somewhere between 21 and 24 years in these three countries. Being diagnosed with schizophrenia decreased the mortality risk with between 16 and 20 years. Being diagnosed with affective disorders decreased the life expectancy with between 16 and 18 years. And being diagnosed with a severe personality disorder decreased the risk, lowered the life expectancy with 22 to 13 years. So being diagnosed is associated with an increased mortality rate and a very much increase in the loss of life. So the life expectancy decreases a lot. I talked briefly before about different causes of death, and this is why we do not see that much in cancer as compared to the general population, as these patients do not gain the age where they have a very severely increased risk of cancer. Looking at mortality over the years, looking at the mortality gap for patients with schizophrenia. We did a nationwide study from 1980 to 2010, where we saw patients in the two lower figures diagnosed with schizophrenia having a stable age at death compared to the general population, where we saw an increase in age of death. As cardiovascular disease is one of the main causes of death, some of what we see here is that patients in the general population has gained a lot over time by the improvements in treatment. So having coronary artery graphies, being able to see if there's a blood clot, being able to put in a stent, open up that artery, being able to do a bypass operation, being able to do primary prophylaxis, being able to do secondary and tertiary prophylaxis after an acute myocardial infarction has gained, especially when we look at the general population. And when we look specifically in a moment at cardiovascular disease, we do not see the same gains in patients with schizophrenia. Just skip this one. Just, I want to point out, it's similar what we see in patients with bipolar disorder. So patients with bipolar disorder is also severe mental illness, and we see similar patterns, although it's not similar in magnitude. Patients with severe mental disorders most often die at a very high rate early on after diagnosis, and then their standardized mortality rates decrease over time, but it still increases as compared to the general population. In this study we also did on Danish register-based data. We showed that patients on the top graph had an increased rate of mortality as compared to the general population. We saw an increase in the mortality rate, standardized mortality rate from 1995 until 2014 for patients on top with schizophrenia. So the mortality gap increased, and on the lower graph, it's patients with bipolar disorder. So we're seeing an increase in mortality in these patients, which might be associated either with patients in the general population being treated better and having a better outcome, or patients from the severe mental illness group having a poorer outcome, either as a consequence of lack of treatment or other risk factors that have increased over time. Previously, we talked a bit about what antipsychotics did, and antipsychotics are more commonly used, but it doesn't seem like that these drugs are the ones that's driving this. When looking at register-based or real-world evidence data, it's important to remember that we have some limitations. All-cause mortality is extremely valid in most register-based studies. Doctors pretty much agree, is a patient dead or not? So the validity of being diagnosed or having a death certificate made out is pretty good. We have lower specificity and lower validity of specific causes of death. That's sometimes handled by dividing causes of death into natural cause mortality and unnatural cause mortality, suicides, homicides, accidents. And then the least specific mortality is if we subdivide into specific causes, let's say infection, cardiovascular disease, similar things. This is due to a very low proportion of patients being autopsied, so we are unsure of how specific this is. Some diagnoses might be more valid. For cardiovascular disease, there can be some benefits in looking into procedures. So if the patient comes in, if they are given a coronary arterography, if you have lab values, you can, with increasingly certainty, diagnose a acute coronary syndrome. or you could also say it's not that. So, oops, that's the wrong way. There you go. So, looking at the risk of cardiovascular disease, initially it's important to discuss, do we find the disease in patients? We looked at a database here in Denmark where we looked at electrocardiographs, looking at were there any signs of previous myocardial infarctions in patients with schizophrenia. We know in the general population, approximately 25 to 30% will have in their ECG signs of a previous myocardial infarction, Q signs. If we look at patients with schizophrenia, we saw that ECG in approximately 30%, in approximately 30 out of a total of 40 patients, we had signs of myocardial infarctions, but no diagnosis. So it seems like in this rather small sample, just 1,000 patients, it seems like approximately 75% of these patients which have signs of a myocardial infarction in their ECG do not get a diagnosis. I'll a bit later come to both patient-related factors, but also come to perhaps system-related factors, which increase the risk of not having a procedure done and not having a diagnosis made. But it is interesting that approximately 75% of patients do have signs of a previous myocardial infarctions, but only 25% are given the diagnosis. Also, this was a PhD thesis by Bjarke Risgaard, who looked at sudden cardiac death. Do we see a large proportion of patients dying where we have no specific cause? We do not have any known diagnosis. We do not have any previous cause which we would suspect would result in sudden cardiac death. So it's not patients who have long QT, it's not patients who have congenital heart defects, things like that. So here we saw in the general population for the total population, 4.5% in the general population had sudden cardiac death. If we only looked at no previous psychiatric diagnosis, 3.8% had sudden cardiac death. But in patients with a previous psychiatric diagnosis, almost 15% had a sudden cardiac death. It's extremely more common in men as compared to women. 4.8% of persons who do not have a previous psychiatric contact died of sudden cardiac death, as compared to almost 26% of men who had a previous psychiatric hospital contact. The difference is smaller in females. 2.8% of patients who did not have a previous psychiatric hospital contact had sudden cardiac death, as compared to almost 6% in those who had a previous psychiatric hospital contact. So sudden cardiac death happens a lot more frequent in patients who have a psychiatric diagnosis, and also especially in men. Looking at time trends in use of coronary procedures, baseline guideline-based therapies, and the all-cause mortality in patients who experience acute coronary syndrome in patients with schizophrenia. We looked at what happened over time. Initially, from the time period of 1996 to 2015, in total in Denmark, almost 220,000 patients had a diagnosis of acute coronary syndrome. 8,000 of those were patients who had either schizophrenia or had no previous psychiatric contact. We excluded 9,300 patients who had a previous contact to psychiatry. We divided these into almost 900 patients with schizophrenia who experienced acute coronary syndrome. And after excluding those we could not match on age and gender, we matched these patients with 2 psychiatrically healthy controls. Looking at coronary angiography, it's clear to see that it's generally used more over time. The cumulative incidence in the patients who were psychiatrically healthy was approximately 30% in the first time period from 1996 to 2002, increased to 70% in the period from 2003 to 2009, and increased again to almost 80% from 2010 to 15. We saw a similar pattern in patients with schizophrenia, but very importantly, it was lower. So patients in the first time period had 18-19% who experienced CAG. In the next time period, we were approximately on 45 to 50%. And then the last time period, we were approximately on 50%. So 25 to 30% lower use of diagnostic procedures in patients with schizophrenia as compared to the healthy controls. Looking at percutaneous coronary interventions, so putting in stents, we saw no difference over time between the 2 groups in those who have had CAGs, but we had a lower group of patients undergoing CAGs. So we had kind of a group that never got the diagnostic procedure. But those who got the diagnostic procedure had the same approximate intervention. Looking at bypass operations, initially almost nobody diagnosed with schizophrenia underwent bypass. It increased a bit, and in the general population we saw a decrease, most likely due to percutaneous interventions becoming more and more frequently used. Looking at generally coronary cardiovascular disease in patients with severe mental illness, I focused a bit on the Danish data. Looking at international data, we see an even more markedly difference between patients with schizophrenia, patients with bipolar disorder, and the general population. Patients who are diagnosed with a severe mental illness do more rarely receive diagnostic procedures and more rarely receive different interventions if something is diagnosed. So the inequality in treatment is seen in Denmark, but is even more marked in many other countries. When we look at the long-term mortality after myocardial infarction, if you're a cardiologist, you would say if you survive the initial acute coronary syndrome, it's important to implement tertiary prophylaxis. You should decrease cholesterol, you should treat risk factors. It could be increased blood pressure, it could be diet, it could be exercise, it could be a lot of different things you would like to change. Just looking at the raw data, initially, if you look at the little blue dot, which were myocardial infarctions in patients with no psychiatric diagnosis, you see a trend of decreasing standardized mortality rates over time. So we're getting increasingly good at treating patients who have myocardial infarction in the general population. Most likely both the acute intervention, but especially the long-term treatment, where we have an increased focus on which interventions can diminish the risk of another stroke and diminish the risk of dying. Looking at the green dots, which is patients with schizophrenia not having and myocardial infarctions, you see a increased mortality rate, which we saw before. it goes for patients in general with severe mental illness, we see an increased risk of mortality. Looking at patients with schizophrenia who have myocardial infarction, which is the red one, we see kind of a spiking trend in long-term mortality in patients who are diagnosed with myocardial infarction, and the risk of mortality is increasing over time. So despite of getting better and better treatments, despite of being better adept at handling the long-term treatment, patients diagnosed with schizophrenia and other data also support this in at least bipolar disorder do not gain from these improvements in treatment. So increased rates long-term in patients diagnosed with myocardial infarctions and severe mental illness. Then we looked at the association between secondary preventive cardiovascular treatment after myocardial infarction among patients with schizophrenia. We have done the same in bipolar disorder, which is not published yet, but the results are similar. We looked at, did patients get treatment, and were there any difference in mortality rate depending on if you got some treatment, less than optimal treatment, and optimal treatment? Did that have an effect, or does it not really matter in patients with schizophrenia? So initially, looking at the heading named physical comorbidity, patients with schizophrenia have an increased rate of diabetes, 33% compared to 24%, had an increased rate of pulmonary chronic obstructive pulmonary disease, 46% compared to 38%, and hypertension was similar between the two groups. There were more patients who experienced substance misuse in the schizophrenia group. There were less being treated with antiplatelets at diagnosis of acute myocardial infarctions, less who were treated with a vitamin K antagonist, less were treated with beta blockers, less were treated with ACE inhibitors, and less were treated with statins. So in general, after myocardial infarctions, patients were not treated as frequently with drugs that could minimize the risk associated with the long-term after myocardial infarction. Then with these three different models, the first model is crude model, not adjusted for anything. The first adjusted model is the one I think best describes what we would expect to call real-world evidence. It's adjusted for sex, birth year, age of myocardial infarction, calendar year, and if they underwent percutaneous coronary intervention, despite we actually have seen that patients with schizophrenia have a decreased chance of undergoing PCI. The last model, the B model, is adjusted for sex, birth year, age of myocardial infarction, calendar year, percutaneous coronary intervention, diabetes, chronic obstructive pulmonary disease, hypertension, and substance misuse. The last part would, for me, be something I would term the cluster of having schizophrenia. These are in theory modifiable risk factors, but in practice, it's very hard to change substance misuse, chronic obstructive pulmonary disease in patients with schizophrenia as compared to the general population. So if we're looking at the middle model, the model reference with A, you can see from below, in patients not getting any treatment afterwards, there's a risk in the general population, a hazard rate of approximately 4, compared to in the general population, a risk factor of 1 if you got triple treatment. Looking at patients with schizophrenia, there was an increased risk with a factor 14. So it's more dangerous for patients with schizophrenia to get no treatment at all as compared to patients from the general population, where both have gotten a myocardial infarction diagnosis. Being treated with monotherapy doesn't decrease the risk much in patients from the general population. It goes down to 3.7, whereas it has kind of a huge impact in patients with schizophrenia. So just initiating treatment decreases the risk from a factor 14 to 8.5. Going up one more to dual therapy, at least 2 different treatments of the one I mentioned before, antiplatelets, hypertension, drugs, beta blockers, statins, decreases the risk to a factor 7.5 in patients with schizophrenia and 1.8 in patients from the general population. But most remarkably, in patients with schizophrenia, getting optimized treatment, at least 3 different drugs, diminishes the risk of long-term mortality to a number similar to what we see in the general population. So patients with schizophrenia have an inherent increased risk associated with diminishing treatment intensity. But it seems like that we're actually able, if we intensify treatment enough, to diminish the associated increased risk to something similar to what we see in the general population. Looking at specific life years or cause-specific life years lost in patients with mental disorders, this was from a group in Aarhus. We can see that patients with mental disorders has an increased mortality rate per 1,000 patients years compared to the general population without mental disorders on almost every single diagnosis, and an increased mortality rate which is significantly increased on everything. It's very explicit on suicides because the rate of suicides is high in patients with mental disorders and is relatively low in patients without mental disorders. But in absolute numbers, suicide is not a cause of mortality that would impact, if you look at the grand scheme, that much as compared to the physical diseases. Looking at the big diseases, we see a similar pattern in the probability of surviving, depending on how old you are. When you get up to very old age, you will see kind of a survival bias. So the patients with severe mental disorders who survive past 80 years has a risk of mortality very similar to the general population. But looking at the early years, 40, 50, 60, the patients with mental disorders, both men and women, have a bigger area or a reduced probability of surviving due to the different colors being wider. So they have an increased mortality of every single cause of death. That's pretty common. Similar if you see combinations of different mental disorders. Just jump in here. What they did, they looked at initially every single and mental disorder irrespectively of having combinations, but then also looked at different combinations. And what we saw for almost every single combination is an increased mortality rate in patients, irrespective of having one or several diagnoses. Okay, then I'm going to talk a bit about risk factors and also perhaps how we can be a bit discouraged. At least I was a bit discouraged with these data. These data are from a relatively large cohort study that's still ongoing here in Aalborg. 400 patients in total being followed over time. We have baseline data which we published. I'll also talk a bit about the follow-up data which we are analyzing currently. So looking at hepatic stetosis in patients with schizophrenia, we saw that it was very common. Approximately 30% of patients, the patients had some risk factors, increased BMI, Smoking was very frequent. Almost half of our patients smoked. 10% had more than recommended alcohol intake, and almost 60% had metabolic syndrome. Looking at the point prevalence of moderate to severe hepatic stetosis, approximately 22% of our patients had this, patients diagnosed with schizophrenia. But interestingly, we did not find an increased point prevalence as compared to the general Western population. So hepatic stetosis was as common in patients with schizophrenia in this cohort as what we saw in the general population. Similarly, we looked at coronary artery calcium. We did a CT scan, measured Agathon scores, and tried to see, did patients with schizophrenia in our cohort have an increased Agathon score as compared to patients in the to persons in the general population. Agathon scores predicted of future coronary artery disease, at least in the general population. We expected to find an increased Agathon score in patients with schizophrenia, but adjusted for age, we saw similar patterns in patients with schizophrenia as compared to norms from the general population. So both looking at hepatic stetosis, looking at coronary artery calcium, we did not find increased risk of increased prevalences of disease as compared to the general population. We had a theory, hypothesis that patients with schizophrenia would increase more rapidly than what we saw in the general population. And so far, we've just looked into these data, but it doesn't look like that this is the case. So patients with schizophrenia do not have a more rapid increase in Agathon score as compared to the general population. Agathon score only measures calcified plaques in the coronary artery or coronary arteries. So it could be that these patients still have soft plaques which have not calcified yet, and as such we are unable to see the increased risk. Then we looked at cardiovascular autonomic neuropathy in patients with schizophrenia. We were a bit discouraged by the data from cardiovascular proxy outcomes, where we did not find an increased risk. So we got interested in looking at, could there be something related to the wiring of the heart? So do we see neuropathies, or could we perhaps later see an increased risk of arrhythmias? So looking at patients with schizophrenia, we only had approximately 40% who did not have a diagnosis of coronary autonomic neuropathy, compared to 85% of controls. Early CAN was seen in 22%, only 9% of the controls, and manifest CAN was seen in 39% as compared to 6% of the controls. Then we know that CAN is increased in patients with diabetes. There's an increased rate or proportion of patients in our cohort who are diabetics, so we excluded those, but still we saw a increased proportion of patients with early CAN, 20% as compared to 2% in the control group, and 38% with manifest cardiovascular autonomic neuropathy as compared to 5%. So it seems like there's very much an increased risk associated with schizophrenia, not on primarily the cardiovascular risk factors, but at least on neuropathies. This has caused us in Denmark to initiate the MAP study, where patients treated with antipsychotics, both bipolar patients, patients with schizophrenia, have a loop recorder put in. So we're constantly monitoring for arrhythmias for a time period of 2 years. We're aiming at including 500 patients, and we have control data. So we're interested in seeing, do we see more arrhythmias in patients? Because a lot of the data we got in on the cardiovascular side have not proven an increased risk in these patients. So it could be arrhythmias that also causes what we saw on sudden cardiac death and what could perhaps be misdiagnosed as cardiovascular death in some of the real-world evidence data due to the lack of specificity, due to lack of autopsies. Lastly, just a few comments. I saw Benjamin's last part of Benjamin's talk. I didn't see which interventions he proposed. Some of the data on lifestyle changes have been less than encouraging. It seems like it's very hard to move anything on cardiovascular risk factors in patients with schizophrenia spectrum disorders and bipolar disorders. There are small gains, but it is perhaps not the most optimal way of diminishing the increased risk. We saw some of the data on treatment after myocardial infarction. Patients who are at a very high risk of cardiovascular disease benefit from intense treatment. So it could be patients with severe mental disorders, could also benefit with early onset of treatment, pharmacological treatment of risk factors, and also perhaps more intensive treatment. So lower the threshold for initiating treatment, and also stating targets that are perhaps a bit lower for cholesterol, for blood sugar, for hypertension, and also consider adding or initiating some of the new treatments for weight gain, like GLP-1 antagonists. The CHANGE study allocated almost 430 patients into 3 groups. The CHANGE group had a very intense follow-up. Personal trainers followed them to training, getting a meal plan, what you should eat, getting help to grocery shop, whatever they needed. Then some were allocated to care coordination. I can take you to a doctor, I can help you get an appointment, and then there were treatment as usual. The discouraging results were, I'm not going to go through everything, but on everything there was no difference. No difference on 10-year cardiovascular risk, no difference on cardiorespiratory fitness, on FEV1, on waist circumference, on blood pressure, on resting heart rate, on long-term blood sugar, on cholesterol. So no difference between the 3 groups, despite of a very intensive trial of getting patients to initiate treatment, non-pharmacological treatment. So lifestyle change is hard in patients without a psychiatric diagnosis. It's not easier in those with severe mental illness. So looking at what perhaps influences the risk of getting treatment or perhaps lack of treatment, you can divide it into patient factors. So there are these lifestyle factors: lack of exercise, poor dietary patterns, a lot of smoking, a lot of obesity. Our patients get medications that cause changes in metabolic risk factors, even though it seems like that they also gain something on mortality rates. They could have predispositions to cardiometabolic diseases. Data supports common genes between risks of weight gain, cholesterol, etc. in patients with severe mental illness. They have perhaps a lower adherence to treatment, and they have a low health-related literacy. On the other side, we also have healthcare factors. So it seems like there are disparities in somatic healthcare. Patients are not offered the same rates of diagnostic procedures. If they are offered, it takes longer time before they get to the diagnostic procedure and they get the intervention. In general, looking at field studies, there's a negative attitude toward patients with mental illnesses. There's limited mental health literacy among non-mental health healthcare providers. And compared to other big somatic diseases, research in somatic disease in patients with severe mental disorders are insufficiently funded for research. So if you give $100 to cancer research, patients with severe mental disorders get approximately $2. So the question is, could we do more? Most likely. I usually say it's kind of interesting to see when looking at patients with severe mental illness, what we do to help with their mental illness. I work at a bipolar unit. Our patients have the same doctor they see every single time. They have the same nurse they see every single time. They have long-term psychoeducations for being knowledgeable about their psychiatric disorders. If they don't show up, we call them, say, what happened? Why didn't you come? We look at, do they pick up their prescriptions? So we follow them intensely. Interestingly, if we see an increased cholesterol level when we do screening, we usually tell them, oh, please go see your GP. So it's interesting that we think the patient needs all these interventions for their psychiatric disorders, but we think they can easily go see their GP if it's a physical disease. I'm currently writing on a position paper with a group within the ECNP where we are discussing that psychiatrists are also doctors. So for a lot of our patients with severe mental illness, we are, as psychiatrists, the main medical doctor that the patients are going to see. So if we discover during our screening that they have an increased cholesterol level, we should perhaps initiate treatment. If we during our screening see that they have an increased blood pressure, we could perhaps initiate treatment. A lot of the first step treatments are not that difficult. I think we will need help. Looking at UK, they have defined different areas where psychiatrists need to be especially aware, and they have defined interventions. So you kind of have risk areas, you define risk behavior or targets, threshold for doing more. Then you define an intervention, what should you do? Personally, I think the Lister tool is perhaps a bit over-ambitious. I would prefer if there was a single drug stated, if they have, let's say, increased blood pressure, initiate this treatment. And then you should define a target for treatment. And if you do not reach this target, I think you should be able to refer patients to specialized treatment within the hospital. So getting more patients treated would perhaps make it possible to at least initiate a decrease in the currently still increasing mortality gap between severe mental illness and patients diagnosed or without a psychiatric diagnosis. Lastly, I think it's very important to remember that no man is an island entire of itself. Every man is a piece of the continent, a part of the main. So I think we'll need to intensify the collaboration with endocrinology, with cardiovascular or cardiology, so we are better able to treat patients. It could be, at least in Denmark, patients with diabetes who have severe mental illness are given a special treatment now. They're doing more follow-up. They're calling us if the patients do not come to an appointment. So instead of, which was the standard before, patients being discharged from services because they haven't shown up 2 times in a row, now the diabetes centers are contacting the psychiatric department saying, is there a problem? Could we do something else? We know it's very important that we try to follow these patients up, as their risk associated with having, let's say, diabetes is even higher than the general population. Thank you very much for your attention. It's been kind of a marathon with a lot of going around. I hope you enjoyed the comments and also what I had to present. Is there any questions?
René, thank you very much for your inspiring presentation. I think this last idea of delivering an integrated care to our patients is a simple idea, but it's something we are not doing really. We are making an effort in identifying cardiovascular risk factors, increases in weight or BMI, and then, as you said, go to your GP. Have you gone to your GP? Did your GP prescribe you something for this? Nothing else. So probably we are not tackling this issue as we should do, as you said.
We are screening a lot, but we're not doing a lot.
Yeah.
And it's kind of interesting that somewhere on the way to becoming a psychiatrist, the medical doctor got lost. I talked to one of my colleagues who is a professor of diabetes care. He said it's very similar to what we saw for diabetes 30 years ago. So they didn't have a coordinated care. They didn't have what they have now. So the diabetes doctor tried to kind of do things. Now, at least in Denmark, you have coordinated care. So the patient gets followed by the endocrinologist, but also by the ophthalmologist, by cardiovascular doctors for peripheral artery disease. So it's much more coordinated than it was before. But what he also said, which I think is very important for looking at it from a psychiatric context, is they do everything simple by themselves. So they try the simple things first, and if the first or sometimes second treatment doesn't help, then they refer. But the patient is kept within their smaller treatment team until it becomes a bit too complicated. And I think a similar model could work in patients with severe mental illness.
I think it's very important. And also the idea or the fact that the gap in mortality is widening in part or mainly or in part because of the inequalities in the access to healthcare. That's a very strong idea. For instance, in Spain, until very recently, having a diagnosis of schizophrenia was an exclusion criteria for entering bariatric surgery or metabolic surgery. So if we know that schizophrenia is highly associated to obesity, why you are not offering those subjects a very specific, very important treatment, isn't it?
And you could also say, why we're not offering our patients GLP-1 transport inhibitors? Why we're not offering them metformin? I would prefer the first because it's more effective. But if costs is important, then you could do the other thing. But I think we could gain a lot by perhaps thinking less about lifestyle interventions. I don't think we're going to get patients to exercise more or lose weight, but we could mitigate some of the risk by lowering blood pressure, lowering blood glucose, and lowering cholesterol levels. I think there are huge gain from low-hanging fruits in that area.
That's right. That's true. We have a comment from the audience. Thank you very much for the exhibition. I feel that there will little time for so many important things. Thank you. Thanks, René.
I usually go all over the map, so I hope it's not too holistic or too across the board. But I thought there were many areas that I would like just to touch upon.
It's a change in the minds also of the patients, because they usually see us as psychiatrists and not doctors. Yeah. So we have to make an effort also changing their minds that we can provide a holistic care, isn't it?
Yeah, and we should.
We should, yeah. René, thank you very much for your time and your presentation. I think we really enjoy it. Hopefully we'll hear you and see you again in the future. Okay?
Okay.
Thank you very much.
Have a nice day. Bye.
Thank you. Bye.